I have one last video to record that I overlooked, so I'm going to record it now. I've combined the high-risk newborn with the grief chapter in 38, so these are two chapters together, and of course I've condensed them as much as I possibly can. Okay, so we have some stumbling blocks that interfere with our care for these high-risk patients. The high-risk newborn, of course, is any of the ones that we've talked about, the premature babies, the diabetic babies, those particular high-risk patients. High-risk students get counted, I guess. Um, we have ethical questions about resuscitation. So, those are some of our stumbling blocks, and we need to be aware that, it's hard for us to decide whether or not to resuscitate. And it's really not a choice. Mandated in Arkansas state law, if they weigh 350 grams or more, we are required to resuscitate until a physician comes in and either calls the code or takes over the code, or if a pediatrician's there and neonatologist is there, they can say whether or not to start the code. But if you're there by yourself, you'll have to start a code. Early signs of respiratory distress, remember, includes the flaring of the nares, expiratory grunting, retractions, that seesaw breathing, and the apneic breathing. Periodic breathing is normal. That's when they breathe a few times, stop for a second or two, and then start breathing again. That's why you have to count the respirations for a full minute to know what their breathing pattern is. Apnea is defined as a 15 to 20 second cessation. So if you have, most of our apnea monitors are set to go off if there's been 15 to 20 minutes in there. So we're going to see that we have a high risk of preterm, late preterm, and post-term infant, and those that are born with mothers of complications. When you're checking the cardiovascular system, you need to be aware that, low blood pressure, capillary refill that's greater than 3, continued respiratory distress are usually signs of hypovolemic shock. We can't bring them back by doing bagging them. There's a hypovolemia, something has caused them to have blood loss, and we need to get some volume in there. Should always do blood pressures on all 4 extremities so that you can compare them. If the upper ones are different than the lower ones, there may be some type of congenital deformity that we should be investigating. Always, always maintain that body temperature. Babies have to work extremely hard to keep that temperature up. They have a large body surface in relation to their weight. We want to be sure that we keep them in a neutral thermal environment. Usually that means putting them in make sure the room temperature is 78 or thereabouts, which means that your nursery is going to be nice and warm. Be sure that we keep their heads covered with, and remember that we've already gone through the different ways that they lose their body temperature through convection, conduction, radiation, and evaporation. So we need to be sure that we are help preventing those temperature instabilities. The preterm doesn't have enough body fat. The postterm doesn't have enough brown fat because they've already used up those stores to maintain their nutrients and things inside the uterus past the time that the placenta is working. So we want to be sure that we keep them warm so they don't have to work at trying to keep warm, and all they have to work at is trying to keep themselves breathing and digesting and doing their functions they should be doing. course, maintaining adequate nutrition is very important because they won't have normal growth and development without it. Maintenance of adequate nutrition in the preterm is complicated by the problems of not being able to suck and swallow, by possibility of developing an ileus, and they won't be able to digest their food. So, and Miss Candler went over all the GI issues that babies have. So, they have a limited store of nutrients, so we have to make sure that we're giving them small amounts quite frequently because they have problems digesting as well. Have to continually assess the ability for them to digest. So we're giving gavage feedings, we have to check residual and make sure that, if they have too much residual, we have to notify the doctor and stop feedings. Usually whatever residual you find, you always return or you're going to mess up their electrolyte functions. Usually the gavage feedings are done with an OG tube rather than an NG tube because the babies are having difficulty breathing and they're breathe by their nose. We also encourage mom to do breast pump to start with breast milk as it's easier for them to digest. Our preterm neonates are, excuse me, at a high risk. They have problems maintaining their hematological status. They have problems with growth and development potential. They may not develop quite as rapidly as you would think when they're 2 years old. They're only a year and a half old gestational wise. So parental adaptation to a preterm baby is really difficult sometimes with all the equipment that's around them. Of course, our best environment is to keep them in mom until it's term, but sometimes we can't do that, as we talked about in preterm labor. Maintaining their temperature, oxygen therapy. If they're on the vent, we have to work at weaning them off the vent. You have a patient, little pretermer on the vent, whose orders read that they to keep the pulse ox between 92 and 94, and your pulse ox goes down to 88. What are you going to do? Are you going to increase oxygen, or are you going to call the doctor? So you have to make your decisions what you should do. Then, of course, how are you going to place how are you going to check your placement with neonates? It's a very small tube that goes down, so we make sure that we check for residual, and then we put a little bit of air into the syringe, and we listen over the abdominal area for the air bubbles. Also, we can do the pH testing now that's being required for adults. We can do that for the babies as well. Parents can hold their baby during the feeding even if they're on oxygen. A lot of times it helps soothe the baby and helps digestion better and helps lower that down. So letting them suck on a pacifier while they're having OG treatment or OG feeding helps and stimulate them. And so anyway, if they're sucking while they're getting their OG feeds, they associate eating with sucking, so that helps them learn to suck, swallow, and feel full, and they get used to they have to suck to eat. Environmental concerns. We sometimes see environmental stress disorder, where the babies get stressed from all the noise in the neonatal nursery, from the oxygen tanks and suctioning and doors closing and things being slammed on top of their cribs or their incubators. Be sure we're using good developmental care with these babies. There is a lot of interesting things in these chapters that we are not talking about because there's just way too much information for us to use. So I'm not going over all of it. We went through the neonatal resuscitation during our sim lab, so there's no need to go through that again. And of course, we always have to make sure we're doing parental teaching as far as we go. Care of the doing the developmental care has to be well organized. We have to get the baby well organized, and babies are really not well organized. And how we help them do that is through positioning, reducing inappropriate stimuli, make sure we're doing eye contact with them, parental adaptation. They need to be empowered to recognize that they're competent to take care of this preterm baby. So, um, some other complications we're going to be looking at is respiratory distress syndrome. Preterm babies we can give surfactant to try to help mature their lungs after they're born through the ET tube. There are several complications that come along with giving oxygen. One of those is retinopathy of prematurity, which causes the infant to have some problems um, with their eyes because of the oxygen. Some babies have even gone completely blind when they have too much oxygen. The bronchial pulmonary dysplasia is caused by the barotrauma from the pressure of the ventilator and the oxygen toxicity. And those are some things we very rarely see. Patent ductus arteriosus. This is something we're going to study in depth when we go to cardiac peds. But usually when we see that, it fails to close after birth. And sometimes if we are giving them too much oxygen, it doesn't get triggered that it should close, so it will stay open. So we have to watch, make sure whether or not we have a patent ductus arteriosus or not. Interventricular hemorrhage is really predominant with a preterm baby because they don't have very much resistance for their small head and the pressure that they have to go through. Necrotizing enterocolitis is when they get inflammation of the GI mucosa. They're just not ready to eat and their guts shut down. Pain, we know babies actually do feel pain. We can do pain response from their cry, from their grimaces. Pain assessment, they actually make pain scales for infants on how an infant reacts to having a pain stimulation. We can help manage pain, like when they're doing a circumcision, the doctor can give them anesthetic. We can give them sugar water. We can help snuggle them up and make them feel better. So, and there are consequences to for not treating the pain. They have a memory of this pain, and they actually are consequences of it. Mismanagement of it is mainly because we don't believe they have pain, but they respond to that through increased heart rate, blood pressure, variability, and things like that. So, or variability in the heart rate. So there's a lot of things that we can see in trying to manage pain. Postpartum neonates are susceptible to meconium aspirate because their guts are mature, so they're going to poop in utero. They're also can be, excuse me, can also be persistent pulmonary hypertension of the newborn because they have can have that left to right shunting where it stays in persistent fetal circulation and the AV valve doesn't close. Back to the meconium aspiration. If the baby's born crying, we don't do anything. But if we have meconium aspirate, the baby's not crying when it's born, we need to view those cords for meconium and insert an ET tube to look. And if there's not any meconium on the cords, then we can continue on. If there's meconium on the cords, we need to get our meconium aspirator suctioning hooked up so we can suction out the meconium that are on the vocal cords. Once the baby does a gasp, it's going to take down whatever's on the cord, so we have to really be watchful for that. We have small for gestational age and intrauterine growth restriction that we have talked about quite a lot. We've talked about hypoglycemia. We've talked about hyperglycemia. Polycythemia can be a problem with when the babies are held down too low and waited too long to cut their cord, and other things that they can actually develop. We also have large for gestational age, and we usually see these with gestational diabetes. Anticipatory grief is something which that D should be an F. Families experience it when they're told of an impending death of their infant, and this happens a lot if they have a preterm infant. That they need to make sure that that we need to make sure that they're being kept apprised of the condition of them. So they have a real difficult time, but they are, even before they die, they start directing all their attention and energy toward the dying infant. But some people, and I have experienced this, distance themselves from, then don't even visit because, if they pretend that they're not there, or they're trying to ready themselves to be without the baby and have an awful hard time going and visiting the baby. So they will also have that. You'll also see the nursing staff have anticipatory grief because we get really attached to these babies as we take care of them. So we want to think about things that cause, I get attached to the patient. I get attached to the patient's mom, and then when these babies die, we have fallen in love with them, and it's like losing a member of your own family. So we all need grief counseling after losing a baby that's been there for a while. We have to grieve the loss. So the loss of a fetus at any gestational age, whether you're 3 weeks pregnant, 3 months pregnant, right at your due date, that's a loss of fetus at any gestational age. When you have a perinatal loss, that's a stillbirth. In order for it to be a stillbirth, it has to be over 20 weeks gestation. If it's less than 20, it's still considered a miscarriage. Patients can go through acute distress, intense grief, depression, guilt, and it's going to affect every member. It's, always going to be saying, why, it should have been me, it should have been me. There's nursing interventions that we can do, and one of the best nursing interventions that we can do is to just be there and listen and not offer any kind of, well, it's going to be okay, you'll be all right, it's for the best. Those are things we really shouldn't be saying. There's a box on page 936 that you can take a look at that tells you some things about perinatal grief and what we can go through. So in order to help them, we just need to be there and be able to offer them private time. Be sure that there's a thing now called a cuddle cot that keeps the baby cool so that the baby can stay longer in the room with the mama without getting discolored, so that they can stay for hours. It's not something, I don't think they encourage them to hold their babies, and we do take pictures. We take little bits and pieces of hair, the blanket they were in, and we make a little memory box for them. So there are a lot of things that we can do and help them acknowledge, you're sad, you're sorry, how are you doing, what can I do for you, how you must be feeling, would you like to talk about it? But don't be saying things that are kind of like, well, you can always have another baby, or you have to keep on going for her sake. God willed it. These are things you don't want to say to them. So you want to create memories for them to take home so that they can look back. And you take pictures, and you don't usually send the pictures until you call the patient and you tell them that the pictures are there, and when they're ready to see them, then you go get them and sit with them as they look at them. So those are some things we really want to make sure we're looking through. We do have special losses. There's always perinatal diagnoses that have a negative outcome. If you have a Down syndrome baby, if you have a baby who is going to have a neural tube defect, you have congenital anomalies that you've seen, and you know that this baby's going to have, trisomy 18. We're pretty sure you're lucky if the baby even gets to deliver. So you'll usually have a stillborn, but a lot of times that they are born with heart beating and mom's able to hold the baby. until the baby dies. And it's really hard um, for parents to accept these things. Um, if they have multiple, say you have a set of twins, and we had a patient who had a set of twins. They went down to have cardiac caths done at UMS or Children's, I think it's Children. And one of the twins, the cardiac cath punctured through the heart, and the twin died. So they lost one of two, and that's really a difficult loss to um, handle, because you got the one baby and you don't really know how to handle the loss of the other baby that was just like that baby. Adolescent grief. Whoops, sorry about that. Adolescent grief. Teenagers get pregnant, teenagers lose their baby, and teenagers are already very emotional, so it's very difficult for them, very heartbreaking for them to lose a baby, even though they're young and you think that they probably didn't need one. So they're going to really need a lot of emotional support. And this can also be grief from giving their baby up for adoption, because they're going to grieve for that baby. They really didn't, if they would have kept it if they could have, but maybe their parents really didn't want them to. So we really need to be looking into that. Complicated grief is something that is when it lasts for a very long time. It's also called complicated bereavement. So it's really hard for parents to get through this. The longer it lasts, the more likelihood that they really need to have some counseling and treatment done. So what can we as nurses do? We can be there for them. We can allow them to talk, express their feelings. We can acknowledge the baby by name. When you go in, you don't just say the baby, you would say the baby's name, and things that acknowledge that the baby was born and there's been a bad loss in their family. It's always pretty hard for us to realize that. Now we're at the end.